Hello everyone, and thank you Zarko for the kind introduction and for inviting me to this lecture to present our work where we evaluated the adoption and evaluation of the Doha Agreement classification in clinical practice. So in the next 10 minutes, I will share with you the main findings of our study. And just to shortly recap of what Adam already told us, we know that diagnosing groin pain is difficult, not only because of the complex anatomy, but also the confusing terminology. And this was shown nicely in the Delphi study that was performed as part of the Doha Agreement process, where 23 groin experts reported 18 to 22 different terms for 2 presented clinical cases. We know that diagnostic terminology matters. From this systematic review, we know that if clinicians use more medicalized or precise terms, that there's a general shift towards more invasive management and higher anxiety ratings perceived by patients. And if we relate this back to the groin, these are just 4 of the terms that were reported by the experts for a case with pain in the adductor area. And you can imagine that patients may respond differently if they heard a diagnosis, adductor-related groin pain, osteitis pubis, or adductor tenoosseous defect. The Doha Agreement aimed to solve this problem, and during the past 5 years, they gained a lot of academic interest, with currently already over 200 citations. But we don't know if clinicians adopted the classification system in their clinical practice, and if they feel it could be improved. And that's what we aim to investigate. And we mainly focused on the 4 defined clinical entities of groin pain. What we did is that we performed 2 sub-studies. We performed a 2-round Delphi study among the original Doha Agreement offer group, and we performed an e-survey among clinicians treating athletes with groin pain at the FIFA Medical Centers of Excellence and the IOC research centers. And for this talk, I will mainly focus on the adoption part of the Doha Agreement. So if we look at the respondents, we had 23 out of the 24 original Doha Agreement experts that responded to the Delphi study. And we had 51 clinicians responding to the e-survey. So these are the clinicians working at the FIFA and IOC centers. And as you can see over here is that they came from various different countries, and they also had multidisciplinary backgrounds. So we first asked the original Doha Agreement offer group if they adopted the Doha Agreement classification in 4 different parts of their practice, in their communication with patients, with colleagues, in research and in teaching. And what we found is that 73 to 82% reported to always or often use the Doha Agreement classification. But interestingly, also 9 to 18% of the clinicians, so 2 to 4 of the clinicians reported to rarely or never use it. And the main reason by this last group for not using the Doha Agreement classification is that they feel the entity approach is not specific enough for them. We also asked the clinicians working at the FIFA and IOC centers if they use any classification system in their clinical practice. And I think it's good to highlight that during the past 10 years, at least 3 consensus statements appeared that aim to resolve the diagnostic terminology problem in groin pain in athletes. And of the 51 clinicians that responded to the e-survey, 57% reported that they use the Doha Agreement, 29% reported that they don't use any classification system in their clinical practice, and the remaining 14% reported that they use a combination of classification systems. And of this 14%, 12% also uses the Doha Agreement as part of their personal combination of classification system. So we can say that also in this independent group of clinicians, that the Doha Agreement has been widely adopted. If we look closer to the 29% of clinicians that responded to don't use any recommendations of available consensus statements, is that 13.5% responded that they don't know any of the classification systems, and 11.5% responded that they know them, but they prefer a different approach. So in other words, 1 in every 7 clinicians that treat athletes with groin pain is not aware of the consensus statements that address the diagnostic terminology problem. And 1 in every 8 clinicians knows them but prefers a different approach. And this highlights, we think, the importance of appropriate dissemination of consensus statements, but also evaluating the recommendations over time, because you may find out that some clinicians don't find your recommendations useful in clinical practice, or that it could be improved. The second part of our study was more or less a replication of the 2015 Delphi, so where clinical cases were presented and the clinicians were asked to provide the terms that they would use for their most likely diagnosis. And if we look again back to the 2015 Delphi, we had the 23 groin experts over there that reported 9 to 11 different terms for each clinical case as the most likely diagnosis. And the Doha agreement specific terminology was being used by 26 to 39% of the clinicians. The same group, now in our Delphi study, still provided 8 to 11 different terms for each clinical case for the most likely diagnosis. But now the Doha agreement specific terminology was used by 50 to 67% of clinicians. E-survey, we saw that the 51 clinicians provided 12 to 15 different terms for each clinical case for the first most likely diagnosis, and the Doha agreement terminology was used by 43 to 55% of clinicians. So what we see over here again is that the Doha agreement specific terminology is used by the majority of clinicians, but there's still a variety of different diagnostic terms being used by clinicians. That these are mainly the clinicians then that don't use the Doha agreement specific terminology. And this is just one example of one of the cases. This was a case with long-standing groin pain in the lower abdominal area, more specifically in the left inguinal canal area. And these are the results of the e-survey, so the 51 clinicians that provided the first most likely diagnosis for this case. We see that they provided 15 different diagnostic terms, where inguinal-related groin pain was the most chosen term by 43% of clinicians. But interestingly, sportsman's hernia was the second most used term by these clinicians. And as we already heard from Adam as well, is that this term is actually being discouraged because an actual hernia is rarely present in athletes. So just to summarize, the Doha agreement classification system has been widely adopted, not only in the original author group, but also by an independent group of clinicians. And we think this shows a good clinical utility of the classification system, and it can help us clinicians in a unified communication among each other when we talk about a diagnosis for groin pain in athletes. There is, however, still considerable heterogeneity in diagnostic terminology when clinical cases are presented. And 1 in every 4 clinicians is not aware of any recommendations of consensus statements on diagnostic terminology in groin pain in athletes, or they prefer not to use them. And we think, therefore, that future consensus statements should at least include a knowledge transfer and dissemination plan, and they should evaluate their recommendations over time. Lastly, I would like to acknowledge this great group of authors for guiding me throughout the process of this study, and also, of course, all participants that took the time to fill in the Delphi survey or the e-survey. Thank you very much.